You have started screen sharing.
Sir, has it started, sir? Is the second slide visible, sir?
Yes,
Abhijeet.
yes.
Now it is done. Okay, great.
Sir, I am presenting a case of a 60-year-old female patient who is a post-menopausal lady, housemaker by occupation, belonging to lower socioeconomic class, resident of Ahmedabad, Gujarat, presented with chief complaints of lump in the left breast since last 2 years. History of presenting illness. Patient was asymptomatic 2 years back. Then she noticed lump in her left breast, which was insidious in onset, initially smaller in size, which increased progressively in the last 3 months to current size. She also noticed retraction of nipple for the last 2 months. Patient has no complaints of pain over the lump, ulceration of nipple or nipple discharge, no history of loss of appetite or significant weight loss. Patient has no history of fever, trauma to the breast, no history of any lump in the opposite breast or axilla, no history of breathlessness, cough, hemoptysis, no history of abdominal pain, jaundice, headache, vomiting, seizure, no history of any bone pain. Past history. Patient is a known case of type 2 diabetes and hypertension for last 7 years and is taking regular medication for the same. Patient is also operated case of coronary artery bypass grafting 5 years back. Menstrual and obstetric history. The age at menarche was 13 years. Patient has 3 children with no history of abortion. All children are adequately breastfed for up to 2 years. Age at first childbirth is 23. Last childbirth was 30 years ago. Menopause since the last 12 years. Previously, her menstrual cycles were regular. She has no history of oral contraceptive pill usage or hormone replacement therapy usage. Personal history. Patient is a vegetarian. Sleep is undisturbed. No history of loss of appetite, normal bowel and bladder habits. No history of addiction to alcohol, smoking. No history of allergy to any drugs. Family history is not significant. History summary. A 60-year-old postmenopausal lady presented with chief complaints of lump in her left breast since last 2 years, which progressively increased in size in last 3 months associated with nipple discharge.
Examiner, would you like to ask question now or should we proceed with sir?
Anga?
I think we can proceed with the examination if the others are okay.
Yeah.
Dr.
Sanjeev, you want to ask anything in the history?
Only one thing I want to add, Dr. Abhijeet.
Yes.
Because
Yes,
you said coronary artery bypass surgery. So here drug history is very important. So what drugs he is taking at present?
So
If she is on any blood thinner or not, because that will have some clinical implication. So if she is having clopidogrel or blood thinner, then you need to stop this medicine and then think for the core biopsy. So drug history is very important. If you have said that she has undergone coronary bypass surgery 5 year or 4 year back.
Yes, sir. Sir, patient is already on aspirin, clopidogrel, atorvastatin, metoprolol, and for diabetes, she is taking metformin. For hypertension, she is taking enalapril, sir.
Yeah, so please mention it in your history. But once you have said clopidogrel, you should mention it in the history and say that this is the importance. So it will give you an extra additional weight on your history presentation that you have thought for this.
So since we are discussing history right now, let me also point out one thing, Dr. Abhijeet, is that very good presentation. But the main difference between a case presentation and writing an answer in your exam is that a case presentation is a conversation, whereas in the exam, it is a theoretical presentation. So when you're presenting it, the flow has to be like you are conversing with the examiner. Like, for example, reading out the headings, history summary. Instead of that, you should be saying, I would like to summarize the history of the patient as, and in one sentence, give whatever your history is. Okay. That gives you those bonus points.
Yes.
Anything specific in history itself?
I think he has covered everything very well, other than the point that when you are giving me history that she's a diabetic and a hypertensive, the fact that she underwent a CABG is not her history. Her clinical history is that she has ischemic heart disease, and the CABG will come in her treatment history. It has implications. When she's undergone one major surgery, you know that she has undergone at least one episode of general anesthesia.
Okay. Abhijeet, just can you go back to that family history part?
Yes.
Okay. What about her family actually? Have you covered that?
Yes, sir. Sir, patient has 3 sisters.
So have
And-
you mentioned it? Sorry, I missed that part. That's why I'm asking.
Sir, I did not.
You are right, sir. He has not mentioned. Abhijit, I told you the same thing.
Yeah.
That don't say not significant. You have to say that there is no history. The patient has female, male siblings, her mother. You at least you know that they have lived for 50, 60, 70, 80 years, right? Without
Yes.
such a disease. That is actually very important.
The
Nowadays,
second
with
point
genetics
is that
coming up,
because the CA breast has a strong family history part. So how many daughters she has? Because she is 60 years of age.
Yes.
Sir, would you agree with me that it should be covered in a family history?
Certainly.
Huh. Because that is the important part. Where will you cover that? Because that is the question examiner is going to ask you. How many sisters she has?
Sir,
Are they surviving or they are dead? If they died, because of what? You may not mention that, but at least you should mention she is having this many, and because sibling is very important. It has a very strong family history part. Because in today's genetic science has gone that way because it has become very, very important. So in family history, don't mention that family diabetes or that is not important. In case of CA breast, this is very important point.
So what you will have to mention, Abhijit, is, if you don't want to mention all the relatives, at least you will have to let me know what all did you ask for. So does not have a significant family history related to which diseases did you ask for breast cancer, because
Very
it's not just breast cancer that you will be
Yes.
asking for. So all that you will be informing us, right?
Yes, you raised a very good point. Abhijit, which are the other associated disease which can be with apart from diabetes and that is general with case of CA breast?
sir, the patient can be a case of a metabolic syndrome, obesity,
Mhm.
diabetes,
No,
and
no.
hypertension.
We are talking about family history.
Hmm.
Sir, for family history, we will inquire about ovarian cancer,
Very
to
good.
sir, BRCA malignancy. For males, can also look out for prostatic carcinoma, pancreatic BRCA1. It is associated with breast and ovarian cancer, and BRCA2 is associated with along with breast and ovarian with pancreatic, prostatic, and sir, male breast carcinoma and carcinoma of the colon and stomach.
Dr. Abhijit, I want to add one more thing. So when you are giving family history, so try to say about first degree relative and second degree relative. So if you have said about first degree relative and second degree relative, then you are more or less giving the examiner an impression that you have taken the family history properly, as said by others. So you said about what cancer you have asked, who are the family relative first degree and second degree, and then you say that we found nothing significant in the family history when I have taken. So give detail of the family history rather than writing to non-significant. That's the point we are trying to stress.
Yes.
Hmm.
And Abhijit,
And
just for others, what is first degree relative?
who all are first degree relatives,
First
if I
degree-
can make it clear?
Sir, they are the sisters, and the mother of the patient.
Not the
And-
father.
Sir, yes, father, mother, and the sisters that she has, ma'am,
And
And daughter.
children.
and children. Yes.
Fine.
And the last thing, Abhijit, whenever somebody, the examiner asks you a question related to something that you stated, don't put your foot into the mouth by saying things like, unless you're 100% sure that you can take the conversation to the last discussion point. Like you just now told me, in BRCA1, this will happen, in BRCA2, this will happen. Okay, this is inviting for trouble. So unless you know that you can take the discussion right to the end of a BRCA mutated patient's final treatment, don't do that. Okay. I think we can.
Yes. Okay. Examination.
On general examination, the patient was examined after informed consent in adequate daylight exposure in the presence of a female attendant. Patient on examination is conscious, cooperative, well oriented to time, place, and person. Patient's weight is 83 kgs. Height is 160 centimeter with a BMI of 32.4 kilogram per meter square. Patient's pulse is 88 beats per minute, normal in volume. Blood pressure is normal, 136 by 84 millimeter mercury in the right brachial artery in supine position. Patient has no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or any dependent edema. On inspection, inspection has been done in the 4 positions. Inspection has been done in the sitting position with arms by the side, with arms pressed over the waist, arms above the head, and in bending forward position. On inspection with arms by the side, we can appreciate a midline sternotomy scar with a scar for a drain placement in the epigastric region and the left mammary, inframammary crease. Right breast and axilla appear normal. Left breast looks asymmetrical. Nipple areola complex of the left breast is positioned higher than the right. Left breast, there is fullness is present in the lower outer quadrant of the left breast with upward displacement of the breast. Puckering of skin is also present. PUD orange of skin is also present over the lump. On close examination, blackish ulcerated skin is present below the nipple area, post the true cut biopsy status. Left nipple areola complex. In the left nipple areola complex, there is a circumferential nipple retraction present on the left side, and the areola is relatively smaller on the left side. There is no history of nipple discharge bilaterally. There is no visible nipple discharge bilaterally, no cracks, fissure, ulcer, or eczema over the areola, no visible swelling in the axilla or supraclavicular fossa, and arm, thorax, and neck are also, examinations are also normal. On raising arms above the head, the left breast moves upwards, more upwards than the right breast. Left nipple areola complex appears deviated upwards and outwards, and nipple is retracted prominently. With bending forward also, both breasts fall equally, but the nipple retraction became more prominent on the left side. On palpation, I have confirmed my inspectory findings on palpation in both sitting and in supine position. On examination, the right breast and axilla is normal. Left breast on examination, there is no tenderness or no local rise of temperature. A single lump of approximately 8 by 8 centimeter size is palpable, involving the nipple areola complex and mainly involving the lower outer quadrant, and which is slightly extending into the upper outer and lower inner quadrant of the left breast. On palpation, surface is irregular with ill-defined margins and hard consistency. There is no any discharge from nipple. Lump is also fixed to the overlying skin and the adjacent breast tissue, but it is free from muscles like pectoralis major or chest wall, ribs, or serratus anterior. Lump, which is mainly lower.
Please mute yourself. अरे कोई अभिजीत किसी को कौन देख रहा है? Please mute those guys.
Yes. Sir, here is a picture depicting the lump. The lump is mainly present in the lower outer quadrant of the left breast, which is also extending into the upper outer and the lower inner quadrant and behind the areola. Also, PUD orange appearance is visible surrounding the lump area. Now on examination.
I think video will be issue. If it is not working, forget it. Don't worry.
Yes, sir. Video I'm not able to.
It's okay. It's okay. We can ask you later. No, don't worry. Skip it. You wanted what you wanted to show, just mention it and find it.
Sir, I wanted to show the fixity to the underlying structures.
Fine.
Here,
You already mentioned it. Forget. We'll discuss it later on. Okay. Next.
this is tauten the pectoralis major muscle and checking the fixity to the pectoralis major muscle. On lymph node examination in axilla, central group of lymph nodes were palpable and matted. Pectoral groups were not palpable. Brachial were also not palpable. Subscapular not palpable. Apical group also not palpable. Supraclavicular not palpable. So this video depicts the palpation of the pectoral region lymph nodes. For palpation of the pectoral lymph nodes, we have to, sir, I am using my right hand and supporting the left hand of the patient on my right hand, and then insinuating my finger in the.
I think we can skip this part. Let the examiner ask you how to do it rather than showing them. What do you say? Or should we?
Anga?
Yes, sir. So, in the first place, Abhijit, whenever you look at the guidelines and the SOPs for treatment of breast cancer, we always identify the lymph nodes dependent on level 1, level 2, and level 3. So,
Yes.
whenever you describe your lymph nodes for the axilla, considering that this is a general surgery case presentation, you will definitely have to stick to the groups the way you have told me, but then go level wise. Describe the level 1 lymph nodes first, followed by the level 2, and then followed by the level 3. Okay, so don't jump directly to the pectoral. Start from the lowest lymph nodes. So which is your lowest group of lymph nodes in the axilla that you will feel or palpate?
Ma'am, extramammary lymph nodes.
So extramammary lymph nodes, are they able to be palpated separately? Are you able to identify them clinically
Ma'am, in this patient or?
in any patient? What is the way you will identify extramammary separately, then lateral thoracic, lateral wall, or pectoral lymph nodes? Is there any way you can differentiate it clinically?
I don't know.
No. So then again, here we are putting our foot into it, right? So don't comment on something that is not able to be discernible. So you start from your lowest lymph node and describe it accordingly. So at any point, and be fluent. So at any point, like sir said, if I want to stop you and say, okay, skip that, tell me how did you palpate the apical lymph nodes? So then you have to tell me. So now you tell me how did you palpate the apical lymph nodes in this patient?
And before go for that, let me tell you why you are
Yeah.
saying this not palpable, this not this palpable, others are not palpable,
Exactly.
right?
So
And
on the axilla, on the palpation of the axilla, these nodes were palpable, and this is the description.
exactly. And go more detail for description of node. You are said matted means what?
Uh,
Are
sir,
they free? Are they fixed? What is it?
sir,
Mobile or not? But anyway, answer the question asked by ma'am. How
uh,
do you palpate apical node?
so for palpation of apical node, I will insinuate my fingers, my pulp of the fingers in the apex of the axilla and palpate with the pulp of the fingers, ma'am.
Okay. Yeah, good. So now again, this is something which is very crucial because this is a postgraduate presentation. If I ask you, how did you palpate? I insinuated my fingers into the axilla, I pulled them down, whatever. If I ask you, how will you? Then you tell me in that tense. These are important things. And some examiners might hold you for that. So does it mean that you have not palpated? That could be answer. Okay. So this is a good answer. Now tell me, what are the characteristics of the lymph node that you try to identify on palpation?
Ma'am, on palpation of the medial wall of axilla along the chest wall, I was able to identify approx 3 by 3 centimeter size freely mobile structures, but they appear to be the conglomerate of structures, ma'am.
So they were adherent to each other. You were not able to palpate them separately. So that is what, whenever somebody asks you what is matted, is your answer. What else did you look for?
Ma'am, I did not get the question.
What else did you look for in the axilla other than your matted lymph nodes? Were there any other observations?
I have looked for any lymphedema, but there is lymphedema in the axilla. And
If you look at the picture very clearly, what is it that is immediately visible to you on inspection in her axilla? Before you tell me about the lymph node, what are you going to tell me? What is there in the axilla which may prevent you from palpating lymph nodes?
Both sides, Abhijeet, both sides.
Both the sides.
Sir, there is a high amount of axillary fat pad in the axilla of the patient.
Yes. So there is a significantly well-developed axillary pad of fat, which may also be a accessory breast tissue. So you have to tell me the palpation findings of that inspection as well as palpation. Okay. Okay. I have no other questions. Any other? You can go ahead.
Yeah, I have some observations. So in general examination, so have you examined chest, abdomen, and spine? So these three examinations are very important when you are presenting breast case. So you need to present about chest, abdomen, and spine. And why I am saying this?
Sir, to rule out metastasis.
Yeah, so you are saying it's a very advanced breast cancer. So to rule out metastasis in your examination, at least mention that you have examined chest, abdomen, and spine. So always mention it. So this is the one point in general examination I want to add. Second is, whenever you are presenting breast case in the current generation, you need to present about the breast size, cup size, and doses. Okay. So one is the chest size, second is the cup size, and third is the doses. So read about it, how to measure the doses, how to measure the band size, and how to measure the cup size. So you need to start with that in your palpation, that this is the thing I have done. Third thing in the palpation, you said that about its lower quadrant and going to the superior quadrant. So if you want to be more specific in tumor position, you can present it in a clockwise. So feel the breast like a clock. So start is the 12 o'clock and then end at 12 o'clock. So you can say for this patient, it was localized between 2 o'clock to 6 o'clock, and it was close to NSE or retroareolar involving the NSE. So include clockwise presentation in the location only. Also, fourth thing, you said that the tumor was not fixed to the pec major. So anything important structure apart from the pec major, we see the fixity because it's a lateral tumor. So it can to pec major or it can be fixed to some another muscle too. So what's the muscle name? How you will do it? So one you said about pec major and second is serratus. So how you will measure the fixity to serratus anterior?
So to
And
check,
Abhijit, particularly when you mentioned it is lower outer quadrant. That's why sir is asking this. Understand this point for all PGs.
yes. So to check fixity to serratus anterior, I'll ask the patient to stand against the wall, approx 1 arm distance from the wall, and first I will examine the movement of the lymph node in the normal position, and then I'll ask the patient to push the wall, and then I will check the fixity of the lump to the muscle fibers in parallel and perpendicular to the fibers.
Okay, thank you. Thank you very much. And regarding palpation, I think you will come. You have examined the opposite breast and axilla too, right?
Yes, sir. I
Yeah.
have
Need to document that also. Okay.
yes.
Vijay, would you like to ask anything?
Yeah.
How does the size of the lymph node is important? If it is 2 centimeter, now you said that this is 3 centimeter. So let me answer that question saying that whenever a lymph node is 3 centimeter, that means there is certainly extranodal spread. And you should also know the staging according to the lymph node size, number of lymph nodes, whether they are extranodal spread or not. So the TNM staging has to be perfectly noted by you.
Yes.
So this will help you in clearly mentioning the TNM stage. Go ahead.
Okay, continue.
Now palpation of the subscapular group of lymph nodes. I have asked the patient the patient is seated in front of me. I am behind the patient, and I have asked the patient to raise her hand above the head, and now insinuated my fingers in the posterior.
Abhijit, sir has already said that you can skip the description part
Yes.
and tell your positive findings. If the examiners are interested, they will definitely ask you the question how you did it.
Yes. So subscapular group was not palpable. Now supraclavicular group was also not palpable. This is the breast lump, and
Just a minute, can you go back to the last slide, please? The supraclavicular. What is one of the basic instructions that were given to us when we did neck lymph node palpations? Will you examine both the lymph nodes simultaneously in the neck? What can happen if you palpate both lymph node groups in the neck together? What is one of the basic things that you will never do clinically? When palpating the lymph nodes in the neck, you will never palpate lymph node groups on both the sides simultaneously because of a very high risk of precipitating what?
ma'am, it can lead to vagal stimulation.
Yes. So this should not come up, okay?
Yes.
Go ahead.
This is the breast lump with the lymph node. in the axilla. On systemic examination, respiratory system examination, there was bilateral normal vesicular breath sound with no added sounds. Cardiovascular system was also normal in examination. Central nervous system, patient was alert and conscious, and there was no focal deficit. On per abdominal examination, per abdomen was soft, non-tender, no organomegaly or any palpable lump. Bowel sounds were also present. There was no bony tenderness. Per vaginal and per rectal examination was normal.
Have you done a per vaginal and a per rectal examination?
Yes,
Per
ma'am.
vaginal also?
Yes, ma'am. Then summary. I am presenting a case of
Abhijeet, why did madam ask this question?
ma'am, sir, for in per vaginal examination, we look for any tubo.
No, that is fine. That is fine. But why did she ask? Because this is very tricky thing. Remember, from exam point of view, she has asked. I know you will be answering that plate, plumber cell, this, that, Krukenberg. We know everything. That's fine. We are not talking of that.
Do
Because
you
this-
actually perform it in the exam?
That's what the actual point here is.
You normally don't, and even if in the exam you want to do it, you will be told by the supervisor that there is no provision for a PV examination over here. So in that case, you have to specifically mention, I would like to do the per vaginal examination, but was not able to perform. Okay.
That's the point. If you have done,
Don't mention.
yes.
If you have
fine.
not done, don't mention.
And that will be the routine. Remember, because as we know, our exam setup, the same patient is given to multiple students. So you have been already told that don't do this because that will be non-convenient to patient. Patient may not allow it. So in that case, specifically mention, I would like to do PV and PR examination, but it's not done. That is fair enough. Do you understand? Then let the examiner ask, why do you want to do? Then there your answer will come like that. That's the point to be clear to all students. Don't say that I have done it because you might have done one day before because the case might be given to you, but don't say that in exam. Okay, continue.
To summarize my case, I have a 60-year-old postmenopausal lady who is third para and presented with painless progressive left breast lump for the last 2 years with recent onset nipple retraction. On examination, there is a 8 by 8 centimeter non-tender hard lump involving mainly lower outer quadrant extending to the upper outer and lower inner quadrant and the nipple areola complex of the left breast and fixed to the skin and breast tissue, but not fixed to the chest wall, with tawny orange appearance of skin and circumferential nipple retraction. There was a palpable central group of axillary lymph nodes.
Abhijeet, yes. So let us go back. I would like to have some points to be discussed in examination. Go back. Go back, go back, go back. Okay. So the first problem is you have a repetition, lot of repetition. As the madam had said, it should be in a flow. Inspection followed by palpation, no repetition. Here also you have written arm, thorax, neck, normal. Later on it will come. Same thing, no visible swell, like that. So it should be a one time. Don't repeat them and more of a flow. This is palpable, this is not palpable. Still go on palpation. And do not, sir, sorry, keep that one. There was one point. Now go back, sorry. What do you mean by areola appears smaller on left side? What do you mean by that?
Sir, because of the involvement of the areola.
My advice is that don't do this. Don't do this. How will you explain? How then you want to say areola is shrunken? What do you want to say? The point is there again. Say what you can answer. Smart people are not a good people. Do you understand? What I believe is that remain to basic. How much difference is there compared to opposite areola?
So, sir is absolutely correct, Abhijeet. This is a valid point. Of course, there is a visible size difference, and your answer is there right on your slide that there is a circumferential retraction, which is what is causing. But at this point of time, that is not going to lead you. Remember, this is an exam, and here you are leading the examiner towards questions. So don't lead the examiner towards something that you will not be able to, one, have a meaningful discussion on, and second, which might put you in a bigger soup than what you are already in. And for the thing that sir actually told you about non-repetition, even in the summary, like Dr. DG Vijay sir told you, this is an oncology case. This is a case of CA breast. So when you summarize it for me, I need to have a very clear judgment about, are you suspecting a malignancy? If you are suspecting a malignancy, what do you think is the clinical stage of the malignancy at this stage of your observation? Okay, so then you don't have to be so descriptive about 1, 2, 3, 4, 10 points. You just have to tell me, what do you think is a tumor status? What do you think is her nodal status? And what do you think is her metastatic status on your examination, right? Okay.
So at the end of the
Ah.
at the end of the summary, you should be able to, I mean, the examiner should be able to gauge your provisional diagnosis 1, 2, 3, 4, and the stage if it is malignancy.
Another point is that on first in this particular slide, left lipper normal, right? What is the next point? No nipple discharge bilaterally. So one side you are examining only left side, then you are going bilaterally. And which areola you are talking then in next line? Right or left? So that's what I'm trying to tell you. The normal circumstances is there when you start in a MS. Don't give too much say. What we normally do is we say opposite breast is normal. That covers everything. You understand? Unless there is something wrong, it's a different thing. Otherwise, it's a routine in MS. When it is a bilateral organ disease, we usually say normal side first. And it is normal. That covers everything. No need to repeat it. Then you go on a left side and concentrate on that side. Right? Do you understand? Here yourself, as the madam has pointed out, no visible swelling in it. There is a visible swelling in axilla. You are contradicting yourself. Bilaterally visible swelling in axilla. So be careful about that. Because you are not looking for lymph node, you are looking for swelling. Do you understand? There is a difference between that. I understand it, why you wanted to avoid, but that cannot be avoided, which is obvious. So specifically, sir, there is a bilateral fat pad visible on axilla, but no other lump is visible inside the axilla.
Yes.
Do you understand? Next. Sorry, I'll be just for the students, I'm telling it's okay.
Yes, sir, absolutely.
Right? Again, left, right, this, you are not sure what you are trying to do. Once you say nipple is retracted, why you have done this? In between nipple, you are taken about breast. So chronological order should be mentioned. First, complete the nipple part and then go to the breast and lump part. Next. Right? Okay, you have written fixed to overlying skin and breast tissue. Right?
Yes.
No any discharge from nipple, just about that. What do you mean by that? What is difference from inspection here? It's a very simple question. This is not something on pressure, because now you are examining. Understand this point. Otherwise, you already mentioned that in past. No discharge, but no discharge on pressure. That's what actually you wanted to say. I understand that way. I don't know whether you understood it that way or not. Do you understand? No discharge from nipple. Yes.
So it is just a matter of how you put it, Abhijeet.
Exactly.
In inspection, you have to say no visible discharge was seen from any of the nipples. And here you have to say no discharge was elicited from the nipple. Okay. So that shows me that you tried to palpate also.
Yes. Right? That is the difference between palpation and inspection. Do you understand? Same way, you said lump is fixed to overlying skin. What we normally do, skin is less than breast, more than breast, or something like that. How much is it fixed? On one side, you are saying it fixed. Is it fixed or fungated or what? It is only fixed. And the point is that here you are saying it is fixed, right? Then other feature of skin, when are you going to say? How did you know that it is fixed, is fixed to skin? What test did you do?
Sir, on skin pinchity, sir, I pinched the skin and for the fixity of the lump to the skin. Sir, skin was not pinchable.
Okay.
So here you don't say I pinched the skin, because if there is so much of a visible involvement and you see a ulcer and you see that black scar over there, discoloration over there, you are anyways not going to be able to. So you should say I tried to lift the skin of the underlying tumor by pinching it, but was not able to do it. Okay.
Right? Okay. So in inspection, where did you take PUD orange? Sorry, but I forgot it.
Sir, here, first slide.
Right?
Yes.
And nipple comes after breast like that. Do you understand? So just
Yes.
I'm not repeating myself, but be careful.
Yes,
So
sir.
routine, normal side first, nipple areola complex, lump, skin like that. Okay. Anybody would like to add anything? Okay.
No, sir.
Okay. So go to the diagnosis now. I think now I've handed over to all the breast surgeons. Now my job is done. Thank you.
Bhavesh bhai, come up. Abhijeet, so
Yes.
what's your diagnosis?
Sir, my diagnosis is a left-sided locally advanced breast malignancy with no evidence of clinical metastasis. TNM staging is C, T4B, N2, M0, and stage is 3B.
Dr. Vijay?
So when we talk of a clinical staging, you have written up CT4B. What constitutes as a clinical staging for the tumor? What constitutes clinical staging for nodes, and what constitutes clinical staging for M?
Ma'am, for T, for tumor status, T1 is suggestive of less than
No, I'm not asking you the stage. I'm asking you, how will you reach this? Does clinical staging, just by examination, palpation, and taking history, can you give me a true T4 CT stage, a CN stage, and is there a CM stage?
By examination, I can give a clinical T stage and a nodal stage also, ma'am. But for M stage, also I can elicit bony tenderness, but I cannot confirm clinically if it has metastasized or not.
Abhijeet, Dr. Kijal here. So, if you do investigation, will that be included in clinical staging or not? I think that is what madam is meaning. Because
Exactly.
clinically, you would not know M0 clinically. But if
Yeah.
you do radiological investigation, will that be considered as clinical or not? That was the question.
So especially in this case where you have those huge axillary breast tissues, if you didn't have the nodes which were that size, then just by doing a clinical examination, you would not be justified in saying that this is my end stage. So you would say that from my examination and history, the probable clinical stage is this. However, I would like to confirm the same by doing whatever radiological. And M, metastasis is one stage which you will never comment on C. Okay. Clinically, you cannot comment about a metastatic stage of the cancer. Right? Okay. Okay, let's go ahead. Sanjeet, Vijay, any questions? Or we go ahead?
I think you have covered, so we can go ahead.
Let's go ahead.
This is the mammograph of the patient. This is a mammograph of both breasts showing craniocaudal and the mediolateral oblique view. The mammograph shows normal right breast, and on the left breast, skin thickening is present. On the left breast, skin thickening is present with nipple retraction, and in the retroareolar region, a radio-opaque lesion is seen with spiculated margins and microcalcifications. Axilla, ma'am, it is not clearly visible because of the high amount of fat the patient has in the mammogram.
Okay. So, what else do you see on the left breast, which you have not told me on mammogram?
Ma'am, the retromammary and the pectoral fascia.
Yeah. Can you see that?
No, ma'am.
So, is this a adequately taken mammogram?
No, ma'am.
No. Okay. Okay. Go ahead. Next.
Mm, over.
So we take over the investigation part, ma'am, now.
Yeah. So, how would you like to? What is the next test that you would like to do for this patient?
Yes, ma'am. I have taken history and proper physical examination. After that, I will go for a radiological examination. In radiological examination, I will do a bilateral breast mammosonogram, which would be followed by a histology. That I will do a true cut biopsy.
Oh, Abhijit, we see that this looks like a malignancy. Why can't we straight away go for a true cut biopsy and then we may go or may not go for mammogram?
Sir, because if we go straight away for a true cut biopsy, the hemorrhage because of the true cut biopsy can develop, and it can lead to misdiagnosis of the patient. Also, it causes pain to the patient. So during compression imaging of the mammogram, it can lead to misinterpretation.
What is a triple assessment?
Ma'am, in triple assessment, there first is a history and physical examination of the patient, then radiological examination, which consists of bilateral breast mammosonogram, and then a true cut biopsy.
Okay. So for the sake of all the PGs, whenever you talk about a biopsy in the exam, please do not say true cut biopsy. True cut is a brand name. Say call it as a core needle biopsy. Okay. It is a core needle biopsy. True cut is one of the brands of a core needle apparatus. Fine. Okay.
How many cores will you take?
Sorry, sir.
How many cores will you take?
How many cores?
Sir,
3, 5, 7.
Sir, approximately 4 to 5 cores from all the quadrants of the lump. Sir.
Okay, now you have already taken a core biopsy and the patient has bled profusely. Why did that happen?
Ma'am, it can be due to increased vascularity surrounding the lump.
No, not in this patient. What did you forget to do before you took the mammogram and before you sent the patient for a core biopsy? Will you directly jump and do just a mammogram in a patient who has a past history of IHD, CABG? You only told me she is on aspirin, clopidogrel, all of that.
Ma'am, I will first stop the aspirin and clopidogrel that she's on, and then after 5 days of stopping, I will perform
3 days. So that is what you have to mention over here. So whenever it is a trap, whenever the examiner asks you what is the next investigation you'll do, don't just jump and say, oh, I'm going to do a core needle biopsy, because that's the most tempting to these two oncoplastic surgeons who are sitting over here. No, you have to stick to your protocol of answering. I would like to investigate the patient as far as establishing my diagnosis, complete biological diagnosis is concerned, to ensure that I have completed her metastatic workup, and to evaluate her general fitness as far as her tolerance for further therapies is concerned. And then go ahead and describe what will you do for each of it. Okay. Whenever you talk about mammogram, please remember, in most of our patients, because they have dense breast, like even this lady, she also seems to have a dense breast. So there you will make it categorically, you will mention that I would like to do bilateral mammogram and bilateral ultrasound of both the breast and both the underarms and both the supraclavicular fossa. When Dr. Sanjeet was asking you how many cores will you take for a core biopsy, another important question is the breast lump the only thing that you are going to do a core biopsy on, or will you do a biopsy of some other sample also?
Ma'am, I will also biopsy the lymph nodes.
Which lymph nodes?
The lymph nodes that are palpable in the axilla.
Okay. Suppose she has axillary lymph nodes also and supraclavicular also. Then you will biopsy which ones?
I don't know.
What is more critical? What will identify the higher stage?
Supraclavicular.
Exactly. So your aim is not just biopsying everything that is visible. Your aim should be that you want to establish what is the highest stage possible, and because that is how your treatment will be guided on. Okay. Okay. Next. So go ahead. What other tests will you do and how many cores will you take? Sir asked you how many cores will you take?
Ma'am, approximately 4 to 5 cores from every quadrant of the lump, ma'am.
What is the gauge of the core needle that you use routinely?
14 gauge, ma'am.
So in 14 gauge, you will use 5 to 6 cores. What is the size of the sample that you elicit in a 14 gauge needle?
Exact size, I'm not sure.
Mm. So what should be your answer? Your answer should be that the number of cores that I take for a biopsy of a breast lump will depend upon what is the gauge of the needle that I use. Most of the handheld needles that are manual needles which are used in our settings are 18 gauge. There you would need more than 5 to 6 cores. But if you are using a good automated 14 gauge needle, there even 4 good cores of full length would be sufficient for a proper diagnosis as well as immunohistochemistry, right? Am I correct, Dr. Sanjeet?
Yes, yes. So
Okay.
one or two more point. Why you means we said that we need to do ultrasound. So apart from the breast density, what are the additional advantage you will get by doing USG both breast and axilla?
Sir, I will, by doing USG of both the breast and axilla, I will also be able to look for any solid or solid. I will be able to differentiate the solid and cystic components if present in the breast.
And why it is
How is a malignant breast lump classically described on ultrasound?
Sir, a malignant breast lump is a
Echoic. Yeah.
sir, it is taller than wide. It is taller than wide, hypoechoic, and with solid components and with increased vascularity and architectural distortion.
which investigation will give you more information about the nodal status? Is it mammography or is it ultrasound?
Sir, ultrasonography.
Ultrasound is very helpful in examining the nodal basin, and it's generally required. It's a must do. So if you are suspecting malignancy, nodal examination is very difficult to comment on the nodal status by doing simple mammography. So for the nodal status, both for the axilla and SCF, you need to do ultrasound. Second thing, if this is a straightforward locally advanced breast cancer, some satellite, if it is a T2 disease, and if you want to see the satellite lesion, sometime ultrasound is more helpful in defining satellite lesion. So ultrasound is very helpful. So you need to say about ultrasound and you need to say about why you are doing ultrasound. So you need to be very clear about why ultrasound, why mammography. And you said core biopsy. Why core biopsy? Why not FNSC here?
Sir, by doing FNSC, we cannot rule out difference between in situ and an invasive cancer, and also the ERPR and HER2 status, the hormonal status can also be not known by FNSC.
And quality of the tissue is very high in the core biopsy. What's the false negative rate of the FNSC?
Sir, approximately 35 to 36%.
So false negative rate of the FNSC is high. So if you're doing false negative, if you're doing FNSC, you may miss the malignancy on histopathological examination. So there are multiple advantages of doing core biopsy. This question may be asked to you: why not FNSC? Why not core biopsy?
Yes, sir. Very valid point. As a general surgeon, I would, because the many surgeons they ask, is it not sufficient to do FNAC? But in CA breast for all students, we have come a long way. So in today's scenario, stick to core biopsy. There are certain exceptions are there that they can tell you, but mainly core biopsy is a must. I think, am I right, sir?
Must only to, you need to aware of what's the advantage of doing core biopsy.
Yes. all the advantage, because the onco physician is sitting there, he will always jump to that. If you say, Bhavesh, what is your
Bhavesh,
take?
Bhavesh bhai,
Think he's
I think
sleeping.
he was
Bhavesh is not
Sir, it
there.
is the Dr. Bhavesh here, sir. Definitely, it is a very important thing, and we should take a core biopsy to now molecular panels and to do NGS, to do so many other tests also. It is definitely required a core biopsy. We will discuss that once we are able to final the case and what are the different tests or investigation. I would like to tell or describe the things or importance of the core biopsy.
Okay, great, Bhavesh.
thank you,
For
Bhavesh.
the panel discuss, just for my point of view, this is locally advanced CA, so there is no question that we have to go for. But suppose it's an early CA brace, still the core, and we are planning of doing, I think MRM for a general surgeon, just a theoretical. Is it mandatory to do core biopsy, or in those cases FNAC will be okay? Because the students may be asked such questions.
No, sir. Even for a small tumor, a core needle biopsy with a complete immunohistological examination before the first step of treatment is administered is mandatory, because now the treatment for breast cancer is based on the biological status of the tumor. And even if it is a small tumor, there in some cases, in some of the biologies, giving neoadjuvant chemotherapy gives better results and is what is the state of treatment. We will, like Bhavesh said, we will discuss it once we reach
Yeah.
the treatment
But
stage.
that's the point I want to, yes, I agree,
It's
absolutely.
mandatory. In fact, the only place where I would probably accept, and that also in the the most constrained strata, is where the disease is absolutely too advanced for any treatment, and the only treatment that I have to give is decide on palliative treatment, is where I may accept FNAC. But even there, as a individual case, I personally would not accept that.
And what about axilla?
And the guidelines would suggest that axillary lymph nodes should be biopsied when they are suspected to have, like Dr. Sanjeet very rightly said, the clinical staging of axillary lymph nodes includes clinical examination and ultrasonographic examination. So if both these are highly suggestive of a clinically node negative axilla, then you do not need to subject the patient for any axillary biopsy. However, in either of these or both of these, if there is a suspicion that is a clinically node positive axilla, then definitely we need to biopsy the axillary lymph nodes. If the expertise for biopsy of the axillary lymph nodes is not possible, this is a place where I might accept a FNAC, a good
Yes, that's
FNAC.
actually that, Panga, that was my question.
Yeah,
You have
yeah,
done core biopsy of a main tumor. So
yeah.
is it necessary to do palpable axillary node core biopsy, or FNAC is okay? This is the question which is asked.
Yeah.
I will like opinion of Vijay and Sanjit both. I think so.
I also feel that here FNAC of the axillary lymph node is sufficient, because the multiple core, if you are subjecting multiple core to the patient, first it's uncumbersome. The patient has to go for the 2 biopsy. So FNAC of the simple axillary lymph node
Yes.
is acceptable.
That's what we follow. Just I wanted to clarify.
Yeah,
But
yeah.
ideal, as man
We-
said, ideal is the biopsy.
Yes,
Yeah.
yes.
Ideal is the biopsy, and the only situation where I would probably insist for a core biopsy of the lymph node is where, not in this case, but when I have a multifocal breast cancer and I want to see what is that biology which has gone to the lymph nodes, is where I would insist on a core needle biopsy of the lymph node and a immunohistochemistry also of the lymph node. So I will have 2 studies, and if there is a heterogeneity amongst the multifocal tumors, then that is identified with that nodal biopsy. Okay, I think we can go ahead.
Yes. But because this is why I raised this point, because as a general surgeon, these are very commonly asked questions.
Yes, sir. Yes.
Particularly this particular question, even I have faced many times. You are already having a core biopsy. Why not only FNAC for a palpable?
No, we can very well just stop at a FNAC of the lymph nodes.
Yeah.
Okay,
Fine.
only one thing I want to add. Now it's diagnosed breast cancer. So would you like to add more testing here? It's a CT4BN2M0, CT4BN2 disease. We discussed it. Only I want to take out from you. So mammography you have done, ultrasonography you have done the biopsy. It's confirmed invasive ductal cancer, and ER/PR and HER2 we will say what is. So would you like to do more testing here, or you will directly go for the treatment?
Sir, since it is a locally advanced breast carcinoma, we will go for a metastatic workup.
So
Uh,
metastatic workup is very necessary to give the postgraduate. So once you have done the staging, you have clinically confirmed the histopathologically confirmed the clinical finding, then you need to do the metastatic workup. And where we do metastatic workup, in which stage we do metastatic workup?
Sir, for locally advanced breast carcinoma, that is T3, T4, and N2, N3, we do a metastatic workup. Or if it is early breast carcinoma and the patient is symptomatic with the symptomatic, then or the ALP is raised, then we will go for metastatic workups.
A very, very nice answer. So one is stage 3 breast cancer or locally advanced breast cancer. And second, even if it is early breast cancer on your clinical examination, but if you are seeing symptoms of the metastasis, just like spine pain or the jaundice or the raised LFT, so you need to see your normal clinical examination. And if you're finding something suspicious on your normal clinical examination and lab examination, then you need to think for metastatic workup, even for early breast cancer patient.
So, what ahead? Can we go for treatment plan, sir? Dr. Sanjay?
Yes, yes,
Vijay?
yes.
Okay.
Before treatment plan, the investigations like PET scan, whether it is compulsory in locally advanced or whether CT scan is enough.
Sir,
Or
PET,
MRI.
So look, there are multiple way of doing metastatic workup depending upon the resource. So one is PET CT scan. If the PET CT scan is not available, then CT thorax, whole abdomen, and bone is scanned. So if you go to the NCCN guideline, NCCN has given the guideline for low resource setting, intermediate resource setting, and the advanced resource setting. So in a very low resource setting in the village, even in the NCCN is recommending ultrasound whole abdomen, chest X-ray, and the alkaline phosphatase. But that's not the case. You should try even if you have availability of the metastatic workup. So metastatic workup can be done in a different way depending upon the availability of the resources and the financial status of the patient.
What is recommended actually in this case, particularly the suppose Abhijeet, you are asked that, okay, what further? Because it is a locally advanced metastatic workup is necessary. So will you do it now or what? So the PET scan is there or something else you will do? Answer on your side. So then we can discuss it further.
sir, I will go for a CECT thorax pelvis, and along with I will also go for a bone scan to rule out the bony emits.
Why not a PET CT scan?
When PET CT scan, it can also be done. It can show both the components in a single. It can also be done.
So then why did you not opt for it in the first place?
Ma'am, because it is costly.
Huh?
So when you give
Cost
an
of
answer in the exam,
Pankaj sir,
when in the
Modi
exams,
sir
you
already
give
gave.
exam in a
Dr.
locally
Modi
advanced disease.
sir,
PET
Sorry,
CT is the
just a
treatment
minute,
of
just a
choice.
minute. Please.
Dr. Modi sir already gave you the answer very well that you were. This is a locally advanced breast cancer. We are talking about ideal conditions in a case presentation in the exam. So your answer has to be what would you
Yes.
ideally like to do? And if the examiner says, oh, this is a poor patient, you are from a resource crunch place, then what will you do? Then what will you do? So then you keep on stepping down, okay? But don't straight away decide that this is a poor patient, I'm not going to offer her PET CT scan.
Yes,
Okay.
exactly. That's what my point was. What I want to ask all of you is that suppose this is your patient, would you do PET CT first or something else? That's what I wanted to know, because the students should be very clear that what they should do and what we are doing maybe is a little different, but just what? Because it is locally advanced CA. Sanjit sir?
Completely agree.
So we should go for PET scan.
Yeah.
Yes. Even I believe that patient should go. Vijay?
Excel.
Kinjal, you were saying something. Kinjal bhai.
Yeah, so I was saying the same thing that for a locally advanced tumor, you don't talk about the finances. It has to be a PET CT. And one more question, Abhijeet, to you is if you do a PET CT for this patient and you find there are multiple lung lesions and multiple bone lesions, any more investigation you would like to do except PET CT scan for such a case where you already find there are multiple lung and bone lesions? Would you do anything else? Any
Uh,
site which is not very clearly visible on PET CT? Any particular site? And you would do something else for that? For metastatic workup?
What is not very well seen on a PET CT scan?
Abhijeet, if you don't know, say I don't know, so you can answer, please.
I don't know.
Ah,
So for brain lesions, so brain is something which is not very well picked up by PET CT. If there are small brain lesions, because FDG uptake is already there in the normal brain. So sometimes, small brain lesions is not picked up by a PET CT. So when a patient has a metastatic disease and, very, very high chance of brain lesions also, you might do a complementary brain MRI also. So in a primary tumor of breast or lung, in such a scenario, you add brain MRI also with contrast to know if there are small lesions in the brain.
one of the student had answer on chat. Pujan, I think. Yeah. MRI brain. Okay. So we agree, so PET scan should be done. Okay.
Yeah. Okay.
So further now, please carry on.
So how would you like to manage this patient? You have already diagnosed it, and so how are you going to proceed?
We consider that there are no metastases. This is the thing. What you see is available.
Okay, we can
This
do
is
it
CT4,
without
BC,
metastasis
N2.
now and with metastasis later.
Yes, later. Yes, sir. Yes, sir.
So Dr. Pankaj, sorry, I'm interrupting. I have to leave. I have some personal commitment around 10 o'clock. So
Okay,
thank
no
you.
problem.
Thank you,
very
sir.
much.
Thank you for
Thank you
joining,
very
sir.
much, sir.
Thanks.
Bye, Sanjeev.
Right.
Bye. Thank you for coming. We are obliged. Vijay, you are there?
Yes, sir, I am there.
Thank
But
you,
I
thank
think
you,
you are
Vijay.
in still hangover, I think.
So on
No, no, no.
investigations.
Mahabalipuram.
So, good for us.
So Abhijeet, start
Ah.
your treatment plan.
Because now it is now your turn. Your turn it is now. I think Bhavesh will be required more.
Yeah, Bhavesh will be more than happy to join.
Okay, because now it is not my turf. I can do MRM. I don't
So
do
before we go on hypothetical situations, do you actually know what was the immunohistochemistry in this particular case?
Very
Abhishek?
good. Yes.
Yes,
Will you
the
tell me?
patient is a triple negative breast cancer.
Wonderful. Bhavesh is absolutely grinning ear to ear. So, so this is a CT4B CN2 disease. We at this point of time will believe that there is no distant metastasis. How are you going to proceed in a triple negative CT4B CN2 disease?
Ma'am, first I will go on with a neoadjuvant chemotherapy. That the patient will be operated. I will do the surgery, and then after surgery, I will go for a radiotherapy.
Be
So
a
who
little
will
more
decide?
specific.
Who will
Be a little
decide?
more specific. Yeah.
Multi-
Sorry, Anga. Sorry.
Who will decide this?
Ma'am, a multidisciplinary team.
Exactly. So that is what Dr. Apurva was telling you. Be exact. With the primary diagnosis and staging having been established, this patient will be referred to the multidisciplinary team where the most probable, as per the guidelines, the flow of treatment would be neoadjuvant chemotherapy, followed by primary surgery and followed by further adjuvant treatment in the form of radiation therapy. Now, is this what do you expect this patient to have? Yes, Pujan, tumor board is one of the names which is used commonly, but multidisciplinary treatment is the more scientific name to it. Yeah, go ahead, Abhijeet. Describe the treatment. What would be the the course? What would you do? How many chemotherapies would you give?
Bhavesh,
Yes, sir.
and now it is your turn. You were telling something
Yes, sir.
about what other specific things you would like to do before that. So this is the time, I think.
Yeah.
So this patient is a 60 years, 62 years, is a postmenopausal. Suppose this patient is a 26 years, very young and triple negative. So in the investigation, you should also do a BRCA testing.
Yes.
In fact, now as per the new recommendations under 65, you should do it for all triple negative breast cancer patients. Okay.
Yes.
Okay.
What are the, since this is a triple negative breast cancer patient, what are the chemotherapies that you are looking at, and will it differ in this particular patient?
Ma'am,
Especially considering your cardiac status.
Yes, sir. Ma'am, the recommended chemotherapy regimen currently is adriamycin cyclophosphamide, 4 cycles, thrice weekly, followed by a taxane-based regimen, which is once weekly or a thrice weekly regime. So 4 plus 4, total 8 cycles are given of adjuvant chemotherapy. But adriamycin being a anthracycline cardiotoxic drug, and my patient is already an operated case of a coronary artery bypass.
Any investigation you would want to do before starting the chemotherapy?
Yes, sir. 2D echo and ECG for a cardiac status. Also, sir, I will do a complete blood workup.
Yes, that is the basic investigation that you would do. But please also remember, all of you, that when it is a diagnosed and treated case of ischemic heart disease, just doing a ECG and a 2D echo is not going to give you a complete clearance of her cardiac status, because it is not just adriamycin which is going to affect her, but eventually you are also going to subject her to radiation therapy. So before you start any such treatment, get her complete cardiac evaluation done by the treating cardiologist, and then only in conjunction with that, your medical oncologist is going to decide what is the type of treatment the patient is going to receive. Now, like Bhavesh Bhai just told you, suppose this was a younger patient, then would there have been a difference in the type of chemotherapy that you would give the patient, or the way you would give the chemotherapy? Have you heard of dose-dense chemotherapy?
Yes, ma'am. Dose dense means taxane, giving 4 cycles of a taxane-based regimen weekly. Four
Weekly?
4 cycles
No,
of
no, that is not dose dense. No, that is not dose dense.
No, that is not dose dense. So dose dense chemotherapy, I'll just take this. If Bhavesh is here, he can take it. Dose dense
Yes, madam.
chemotherapy.
Bhavesh
Yes,
bhai.
sir, can you take it, please? About dose dense. Yeah.
The concept of the dose dense chemotherapy, especially in a young patients, or where you feel that biology is aggressive and you want to kill, or the cancer cells should not be left, the instead of 3 weekly regimen, we are giving every 15 days. It's a 2 weekly regimen. So that is generally anthracyclines or cyclophosphamide, that is AC protocols. Generally, we are giving 2 weekly, followed by weekly paclitaxels. That is a 12 week. So total, generally, if we give the taxane 3 weekly, we are giving 4 cycles, but instead of that, weekly 12 cycles, or dose dense, the AC cycles, that is every 15 days.
So giving these dose-dense chemotherapies not only helps in tackling those aggressive cancers in a more effective way, but it also addresses cancer resistance. Remember, more aggressive your cancer, more likely the cancer is to develop resistance. And that is where the medical oncologists go in and they evaluate which is the patient who is more likely to have these, and then subject them. So that is one more thing that you should know as a surgeon, that dose densing is something that they will consider in high risk breast cancer patients, okay? Younger, premenopausal, triple negative cancers, okay? Now, for how long will you continue the neoadjuvant chemotherapy?
Ma'am, I will first give 2 cycles of adjuvant chemotherapy, and I wait for the response. The
You will
patient,
give chemotherapy?
no,
The patient will be given.
Yes, ma'am.
Bhavesh will throw us all out if you give chemotherapy. So the patient will receive 2 cycles of chemotherapy. Then what?
The patient will receive 2 cycles of chemotherapy. Then the patient will be evaluated on the response of the patient by RECIST criteria. We will divide the patient into 4 criteria. If the patient has a complete remission of the disease, or if there is partial remission, then we will go ahead and complete the neoadjuvant chemotherapy, which will be followed by a surgery later on. If the patient has a stable disease or a progressive disease, then we will stop the neoadjuvant chemotherapy. The surgery will be done upfront, and it will be followed by adjuvant therapy, which will be second line.
Now, whenever you talk about evaluation of response to chemotherapy, this is a locally advanced breast cancer. Modi sir just told us that patient has already said that she wants to go ahead with a MRM. So why do you want to evaluate response? Just complete the chemotherapy. Will you gain something more by evaluating the response where the patient doesn't want to opt for breast conservative surgery? So whenever you are evaluating response, the first thing you are evaluating is the chemotherapy effective in the first place, irrespective of whether you are downsizing or downstaging, okay? Because in this patient, it is not just downsizing, but it is the primary line of care, okay? So then next question comes is, how will you evaluate this patient and with what investigations?
Abhijeet, the madam has asked a question. In first place, why do you want to give chemotherapy to this patient? Why don't you straight away go for MRM?
Sir, because this is a locally advanced carcinoma.
Fine, locally advanced is fine, but it is free from pectoralis major muscle. We can very well do MRM. That doesn't mean that, but the reason why you want to give chemotherapy, and then only you can evaluate is it working or not.
What is the benefit of giving neoadjuvant chemotherapy in this patient ahead of surgery?
So, ma'am, it will decrease the size of the tumor, and during surgery, it will also decrease the vascularity surrounding the tumor. So during surgery, it will be easy to dissect the tumor from the breast and raise the flaps.
But
So
that
you
is
are
what
going
sir
to
is
dissect
saying.
the tumor from breast. You are not going to remove whole breast. Don't confuse breast conservative with the MRM.
I don't know, sir.
Madam.
Another
Neoadjuvant
thing, Abhijeet,
chemotherapy.
the
Yeah.
advantage of the
Yes.
neoadjuvant chemotherapy on day one, every breast cancer we feel it is a micrometastasis on day
Exactly.
one. So that's why we want to prevent, or we want to give systemic therapy to prevent the micrometastasis and to ultimately find a good overall survival, because
Yes.
this patient is going to likely to have a relapse on a longer run. So suppose you are not giving neoadjuvant and you are giving directly surgery, and then this type of patient will definitely end up in a metastatic disease.
Exactly. So what
So
we
this,
call as a surgeon is that it is a systemic disease, not CA breast only.
right. Sir.
Remember,
So
unless, yes.
So this brings us to the very important point that whenever you talk about treatment of a cancer patient, you need to decide on day one, what is the intention of your treatment? Are you treating with a curative intent? Are you treating with a palliative intent? The second you need to understand is, what are the priorities or goals of treating a cancer patient? The first and foremost priority is that you need to ensure that her overall survival is the best overall survival that you can give her. The second priority is, how can you make sure that the disease-free interval or the disease-free survival is the longest that can be in this case. The third is, you have to ensure, how can you ensure that the quality of life of this patient is maintained to the best possible standard that you can give her. And that is where comes come all your points about, will you be able to save her breast, what sort of a treatment will you be able to give her surgically, etc. But the first thing, overall survival, second, disease-free survival, and third, quality of life, including decisions relating to cosmetic and reconstructive surgery. Okay, this is the bottom line and this has to be followed. And whenever you think of giving neoadjuvant chemotherapy in locally advanced diseases, your primary aim is to ensure that her overall survival gain is the maximum.
Yeah.
And
The
that is what a
question-
neoadjuvant chemotherapy does for you.
Bhavesh and Vijay, I have a question for you. Suppose, can you think of breast conservative surgery in this patient if you can prove there are no metastasis? And will it change your approach of chemotherapy? Vijay?
No, sir. I would not consider breast conservation in this patient because she has got extensive edema of the skin.
Yeah.
If they have limited edema of the skin and it responds completely to neoadjuvant chemo, I might consider. But if you see the mammogram, there is lot of edema.
Yeah.
Best to do a modified radical mastectomy for this patient.
Yes, that's when for the student point of view, I'm asking that because this question will be asked to them. So will it change your approach to chemotherapy, Bhavesh?
No, not at all, sir. The most important is I will definitely continue. But sir, another with this question, another thought of suppose by giving neoadjuvant chemotherapy, there is some progression. Then what to do?
Yeah.
So there is a twist now in the story.
Yes, we always think of regression, but there is a progress.
Abhijeet?
So, Abhijeet, can you do suppose after 2 courses of chemotherapy, there is a progression. Now patient complains of bone pain, or now complains there is a altered liver function test, or you feel now there is a liver metastasis.
Yes.
What should be your line of treatment? Or there may be a no metastasis, only fungated mass, or locally is advancing.
Sir, I will go for surgery, and then I will do for a visceral mets. The chemotherapy, second line chemotherapy will be given.
So the point is that definitely whenever on a triple negative breast cancer, locally advanced breast cancer, your overall plan is to give neoadjuvant chemotherapy and then followed by surgery or the MRM. In spite of that, if there is something like,
I think we lost him.
hello?
Yeah, Bhavesh, please.
So if there is a progression or if there is a progression, then you can go for toilet mastectomy.
I think it's a connection.
Yes. So what Dr. Bhavesh is trying to say is that the question that I asked you, what all will you see? You will not only see how the tumor is regressing. In the first place, you will identify if the primary neoadjuvant chemotherapy is working. If the neoadjuvant chemotherapy is not showing adequate response or there is progression on disease, then the decision whether you will do surgery in between or go to second line chemotherapy will again depend upon the resectability of the tumor and the clinical situation of the patient. It is a fungating, bleeding, infected mass. You would rather go in for a toilet mastectomy at that point of time. But if it is still a contained mass and you can, go ahead and try some second line chemotherapy with addition of a new molecule, that can be tried. Okay, so that is the first thing. Now coming to the question about whether you will be able to save the breast in this case or not. I completely agree with Dr. DG that with the amount of edema, you can see it on the mammogram itself, the entire breast skin is edematous. Doing a breast conservative surgery at this point of time is not at all advisable. This was a younger patient. If the patient says that, no, I still want a breast reconstruction, then what is the option that you have? This is the era where we are not just talking about breast conservative surgery, but what now the new dictum is that breast form preserving surgeries. Breast form preserving surgeries include your breast conserving surgeries as well as breast reconstructing surgeries. So in those cases where you unfortunately cannot offer breast saving surgeries or breast conserving surgeries, you can offer them mastectomies with reconstructions, which can be done as a primary reconstruction at the time of the mastectomy or a delayed reconstruction. Okay, so it is not necessary that the patient has to stay with a flat chest. You can definitely advise breast form saving surgeries depending upon the patient's general condition, the patient's requirement, needs, feasibility, availability of expertise, etc. Okay. Okay. Now you have finished your neoadjuvant chemotherapy and there is, your patient is now going to come for surgery. What all investigations will you do before posting her for surgery?
Ma'am, I will repeat the bilateral mammo sonogram.
What will you achieve by repeating it?
I will look for the remaining breast tissue and the contralateral breast, if it has spread to the contralateral breast or not.
But clinically, you said you have a good response. That is why you continued with the neoadjuvant chemotherapy. And the patient has opted for a MRM. What is the role of a mammogram at this stage? So again, whenever you have posted the patient for a modified radical mastectomy post neoadjuvant chemotherapy, in the first place, when the patient did not have distant metastasis and the only disease was in the breast and the axilla, you can very well clinically examine and find that there is no residual disease in the breast or the underarms on either side of the breast. Then you do not need to repeat a mammogram in all the cases. If you want to evaluate the axilla, especially in this patient with the fatty axilla, you can definitely just stop short of an ultrasound of the breast. Mammogram is a painful and a radiation-inducing investigation and should not be done just because we wanted to see how it is. Okay. So an ultrasound itself is sufficient, and then a general workup, and the patient can be posted for surgery. Now you've done a modified radical mastectomy. What are you going to look for it when the modified radical mastectomy histopathology comes? And will it affect further treatment?
Ma'am, I will look for the ER/PR and the HER2 new status.
On the breast specimen, what will you check for? What will you ask the pathologist to look for? You had a tumor, you give chemotherapy, it regressed. Now, what is that you are looking at? Okay, let me ask you, what is PCR?
Ma'am, pathological complete response. It is no ink on the margins.
No.
Lump and
So again, please stop confusing and please stop focusing on breast conservative surgery. Ink on margin, margin on ink, tumor on ink on tumor, whatever these terms are, they are used when you are doing breast conservative surgery and you are looking for margins of your resection. Okay, here we are talking about a modified radical mastectomy. The specimen has gone to the histopathologist. You are looking for PCR. Pathological complete response means absence of invasive disease in the breast or the underarms. Okay, so that is the basic definition of a PCR. You can have breast PCR, you can have axillary PCR, and both combined is total PCR. Okay. So that is where we need to focus on. And how will a PCR affect your further treatment in a triple negative breast cancer? If you know it, you tell me. If you don't, you tell me you don't. Okay. 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 So now there are a couple of biologies of breast cancer where PCR has been.
I think we can request all participants to mute their microphones.
Bhavesh bhai, continue, ma'am.
So, okay, sorry. So there are some biologies in breast cancer now where PCR has been identified as a surrogate marker for your prognosis. And if you reach PCR, then that defines what the further treatment is going to be. And these are the aggressive biologies, your triple negative breast cancer and your HER2 positive breast cancers. If you reach PCR in a triple negative breast cancer, then no further adjuvant systemic therapy is warranted, and the patient straight away goes for adjuvant radiation therapy if she's if she's planned for it. In this case, she will receive adjuvant radiation therapy, and if not, then she just goes into surveillance. In a HER2 positive case, this is not a HER2 positive case, but if it is a HER2 positive case, if there is PCR, then the follow-up adjuvant systemic therapy will be different than the one where the PCR is not reached. Okay, if Bhavesh is around, he will take that answer. But otherwise, this is where your PCR is important. Okay.
yes, madam.
DG, any other questions?
Unlike a conventional mastectomy, you will remove the skin, a little wider in a locally
Yes.
advanced breast cancer because there
Yes.
was edema of the skin.
Yes.
So, don't try to do a skin sparing mastectomy. Remove adequate skin so that you get a good closure.
Yes.
And also maintain the viability of the flaps, because sometimes when we do mastectomy post NSCT, at least for a beginner, there are higher chances of skin necrosis. So the flap thickness is very, very important in a patient who has received neoadjuvant chemo. because in about 3 weeks time, you are also planning to start post-operative radiation. So healing has to be perfect. You should inform the pathologist that the tumor was, as Dr. Sanjit said, in the 5 o'clock position, lower outer quadrant, so that the pathologist can take multiple sections of that particular quadrant to see whether there is any invasive or in situ cancer, especially in that quadrant. Okay.
Yeah.
Bhavesh bhai,
Okay.
any inputs from your side? Maybe he is not available. Okay, ma'am. Okay, we'll continue with the same thing. Any specifics about chemotherapy? And then, of course, I would like to take up on radiation therapy also.
Yeah, so I'll give a comment on the I'll give a comment on the adjuvant chemotherapy also. So this is Kinjal here.
Yeah.
So what happens? This patient after surgery, after the modified radical mastectomy, will be posted for radiotherapy first. Even if the systemic treatment has to be done, it has to be done after radiotherapy. So specifically, let us talk about the TNBC cases where it is a triple negative breast cancer. So wherever it is TNBC, PCR is very important because in TNBC, if we don't achieve PCR, this patient will require adjuvant chemotherapy. So now for that, we need to know the BRCA status of the patient. So as Bhavesh Bhai had mentioned, we would do a BRCA. So if there is a BRCA positivity, so if the patient is BRCA positive and there is no PCR, there is no pathological complete response, we would be giving a drug called olaparib in adjuvant setting after the radiotherapy is over. And if there is no pathological CR in a BRCA negative cases, after radiotherapy, we would be giving them adjuvant chemotherapy in the form of capecitabine. So these two kinds of drugs we give it. If there is no PCR in TNBC, we give adjuvant chemotherapy after radiation. And BRCA positive, we give olaparib. And if BRCA negative, we give capecitabine. That is usually between 6 months to 1 year. And coming back to radiotherapy, radiotherapy is given like whenever we talk about modified radical mastectomy. So chest wall radiotherapy is to be given if the tumor is more than T2N0. So if the tumor is more than T2, like a T3 or a T4 tumor, or any node positive tumors, we need to give adjuvant radiotherapy. So if the patient is upfront operated for a radical mastectomy, we would see the histopathological factors and decide the radiotherapy. Or if it's a neoadjuvant chemotherapy, like in this case, as it was more than T2N0, it was a T4B N2 disease, this patient do require adjuvant radiotherapy to prevent the local recurrence. For any BCS cases, breast conservative surgeries, there is definitely an indication for radiotherapy because it's a breast conservative therapy. It is a BCT, not only BCS. So that includes the part of radiotherapy also. Nowadays, there are exceptions coming for elderly patients. You might omit radiotherapy, but that is only for the MCS students to know, for the MS students. It is beyond T2N0, or if it's a BCS, you have to give adjuvant radiotherapy. You want to ask anything?
Yes,
Kinjal,
yes, Bhavesh bhai.
Apurva, yeah. So the point here is that the standard, if we consider first of all the standard of this particular patient, 60-year-old with history of CABG, instead of anthracycline, I would like to give epirubicin. There is a one cardioprotective anthracycline also. Or the point is, can we avoid anthracyclines? Because anthracycline is a cardiotoxic. As this is HER2 negative, we are not going to use any anti-HER2 molecule. But if at all, if we are HER2 positive and we are using any trastuzumab, that is anti-HER2 molecule, should not be used with anthracycline because both are cardiotoxic. So generally, we are using a HER2 anti-HER2 agent with paclitaxel, not with anthracycline. So this particular case, if 60-year T3 and 2 disease presented with a history of CABG or bypass, I would like to start with 4-EC, that is epirubicin and cyclophosphamide, every 3 weekly for 4 cycles, followed by paclitaxel or docetaxel, any taxanes, 3 weekly. And once we complete the total 8 cycle of chemotherapy, and if there is a very good response, and then we do MRM, modified radical mastectomy, and in that specimen, if the residual, the final histopatho report is YPT2N1, then particularly in that case, when there is a residual disease, when there was no pathological CR, I would like to give capecitabine oral tablet that is for 6 months. Again, 1250 milligram per meter square for total 6 months. If there is a no residual disease, then I just would like to give only radiation therapy adjuvant and keep patient under observation.
Perfect, Bhavesh bhai.
Abhijeet, it was perfect, but did you understand?
Yes. Yes.
Any question? And
Yeah,
now
any questions?
only theoretical now the discussion. I had just complete all this patient. Now just theoretically, if this patient is a young and if this patient is no cardiac problem and if this patient having a BRCA positive, then the scenario is changed. Or if it is ERPR positive and HER2 negative, or it is ERPR negative and HER2 positive. So my first subclassification or the theoretical dissection is if patient is young and BRCA positive or family history positive, I would like to give for olaparib, that is adjuvant for BRCA1 and BRCA2. There are two somatic and germline, and BRCA1 and BRCA2, I would like to go for olaparib, that is at least adjuvant for 2 years. If it is ERPR positive, I would like to go for letrozole, that is a hormonal tablet, adjuvant for 5 years. And if it is HER2 positive, I would like to give trastuzumab, that is 8 milligram per kilogram loading dose, followed by 6 milligram per kilogram for total 17 dose, that is all for 1 year. And if it is HER2 positive also, I would like to add in a neoadjuvant setting, that is with the paclitaxel, and then I would complete or remaining 13 cycles in an adjuvant setting post-surgery. Everything is clear?
Yes.
Any queries to all those students who are sitting by the side? Very well
I think
explained,
any students who have questions, because what will happen, like what Bhavesh bhai told is, very routinely we do, but for the students and MS students, they would not understand everything very clearly. I think you can take our numbers, ma'am's number, PJS's number, my number, Bhavesh bhai's number. You have any doubts, be in touch with us. Either today, tomorrow, whenever you want to be in touch with us, we would be more than happy to teach you, because this is a very big disease. It's not a small disease. So triple negative, ERPR negative, HER2 positive, triple positive, ERPR positive, HER2 negative, all are totally different. We have only discussed TNBC today. So it is, the whole management is different for all patients. So you guys can come back to us, anybody.
Yeah, most welcome.
Angel
And
bhai,
you can type in
Angel
the
bhai.
chat also right now.
Yes, sir.
Yeah.
Yes, sir.
The only improvement in your statement would be not only the PGs, even surgery. See, I mean,
Yes, sir.
we are all, see, why you keep you, DG Vijay, Bhavesh bhai with us is because this is a learning experience for us also. And this student have to understand that even at 55 or 60, we need to learn.
Right, sir.
Thank you,
Sir,
Dr. Purva.
we can come for a lecture there also, sir. We can plan.
More than happy, sir.
We'll be
More than
to
happy.
teach, sir, there. Yes, sir. Yes, sir.
Okay, coming back to surgery, Abhijeet, we have discussed about the MRM and we have discussed about PCR in the MRM. Now, how will you define adequate axillary clearance? We talked about Kinjal sir giving radiation therapy, right? But how is he going to define whether he is going to radiate the breast, the underarms, the axilla and the supraclavicular fossa, or just one of them? That will be on the basis of whether there is complete axillary dissection done or not. So what is the definition of an adequate axillary lymph node dissection?
Ma'am, for adequate lymph node dissection, go up till level 1 and level 2. Level 3 is not routinely dissected.
Again, we've put our foot into it. What is the definition of axillary lymph node dissection? Axillary lymph node dissection is the dissection of the level 1, level 2, and level 3 lymph nodes, where a minimum of 10 lymph nodes have to be identified in the pathology specimen to call it adequate. Whether you will do level 1 or level 2 dissection, limited level 1 or level 2, or you will go up to level 3, will depend upon what was the disease like to begin with, how much was the axillary lymph nodal load. Okay, in this type of a patient where practically all the lymph nodal subgroups are involved and it is a matted type of a lymph node, then it is going to be a complete axillary dissection. How many lymph nodes the pathologist identifies on the histopathology will define whether your axillary treatment was adequate or not. And on the basis of that, the radiation oncologist will define whether he is going to radiate the axilla or he's only going to radiate the chest wall. Okay.
There is a very high probability that there will be a positive lymph node at level 3 also.
In
So,
this case, yes.
you don't, and the margins are also not very clearly defined whether this is level 2 or level 3. Try and reach up to the apex of the axilla, do a complete axillary dissection. Of course, that runs the risk of the patient developing lymphedema, chances are higher. But in spite of that, some of these patients with matted nodes will require a level 1, 2, 3 node, lymph node dissection.
So, Kinjal, any update or how do you give radiation therapy to the chest? And if you do it
Yeah.
to the axilla, what are the complications? Because what we have been taught is something different. So that's why.
Yes, sir. So it is changing. You know, earlier what we used to do was we used to give whenever there was node positivity, after the modified radical mastectomy, we would treat the chest wall, the axilla of the chest wall area, and the axilla of the arm area also, and the supraclavicular region. That is what we used to do traditionally. So there was a very high chance of lymphedema. Nowadays, what we do, if there is a complete axillary dissection, we don't need to treat the axilla. So we treat the chest wall, and if the nodes are positive in the axilla, we treat the supraclavicular region. For a lower, for an inner quadrant disease, or patients who had a internal memory node to begin with, we treat the internal memory nodes also, along with the radiation to chest wall. So earlier, the problem treating internal memory nodes was, there was high dose going to lung and heart. But as the techniques have evolved, we do techniques like IMRT, IGRT, where it's a focused radiotherapy targeting to the chest wall and the nodal region. We can avoid the dose to lung and heart and safely deliver radiation to internal memory, supraclav, and the chest wall. Now there is a paper, where they say that, if you have not done the axillary dissection, you go for radiotherapy. But usually doing a good axillary dissection, you can omit radiation to the axilla and the morbidity would be reduced. Yeah.
Right, sir. So,
Suppose
yes,
this
Anya.
axilla was a node negative axilla to begin with, Abhijeet. Would you still go ahead and do axillary lymph node dissection in this patient?
Ma'am, because it is a LABC, axillary lymph node dissection is required in this patient.
He was
What
node
else you can
negative
do?
to begin
What else
with.
you can do?
We
What
can
else you can do?
retinal lymph node biopsy.
Yes, very much. So there is no restriction on preserving the axilla just because this is a locally advanced breast cancer due to the tumor size in the breast. Whether you can save the axilla or not depends upon whether the nodes were negative, clinically node negative before you started the treatment. That is where you can offer a sentinel lymph node biopsy to this patient, okay?
Yes.
And should be offered to all patients.
What are the
Anya,
three techniques for doing a sentinel lymph node biopsy?
Sir, we can inject a blue dye, methylene blue,
Correct.
approx 2 to 3 ml, or we can go with a technetium labeled sulfur colloid.
Correct.
And can be checked with a handheld gamma probe.
Yeah. Correct. Third.
For third, sir, indocyanine green dye can also be used.
Fantastic. Very good.
How do you improve the sensitivity of the sentinel lymph node biopsy?
By combining the techniques, like methylene blue can be combined with that.
Yes, very good, very good.
So when do we inject?
Sir, we inject in the subareolar region, intradermal, or in the peritumoral region.
When?
Sorry, sir.
And when? Time.
When?
Sir, it can be injected either pre-operatively 1 day before or intraoperatively.
Whoa,
Uh,
1 day before. Is it different for different techniques?
Ma'am, if it is a colloid sulfur, then it can be injected 1 day before, pre-op in the pre-op period, or it can be injected in the intra-op. For dyes, it is injected in the intra-op setting.
Does any other student know the right answer to this? Okay. So in the present era where we are using the radioactive dyes which come to us with the prevalent half-life, it is injected almost 1 to 1.5 hours before surgery. The indocyanine green and the methylene blue dye are injected just before you are going to operate. So usually what we observe in our practice is that it takes around 10 to 15 minutes for the dye to reach the axilla. And so the injection is done. In my practice, I inject after the patient is given anesthesia. And we scrub the patient, we give the dye, we wait for around 10 minutes and we observe the traveling of the dye to the axilla. Usually it takes around 10 to 12 minutes. So maximum 15 minutes before you can put an incision, you would inject the dye. Okay.
Yes, ma'am.
And it is injected circumareolary in the subareolar planes intradermally. And usually most of us inject it at 4 sites. And peritumoral, I personally don't prefer peritumoral injections, especially when I'm planning a breast conservative surgery, because it muddles up my planes and I'm not happier operating in planes with spilled dye in it. Right? Okay. Okay.
One more thing I wanted to discuss was the follow-up of such patients, young patients specifically, young patients who are ERPR positive, that is what routinely we see. Once they have undergone, this therapy and surgery, mostly MRM, how should the follow-up be for such a patient, and how should we track the patient?
Dr. Bhavesh, would you like to take this?
Yes. Yes. The follow-up of this type of patient for first year every 3 months to do X-ray chest, ultrasound abdomen, blood test that includes alkaline phosphatase, clinical examination, and the history part. So ultimately, we want to like to predict, or we would like to detect the early metastasis in a early, where we feel that again early metastatic find out can ultimately help by advocating the final treatment for metastatic disease also at a right time, and to help the patient, the quality of life also important. So total 5-year follow-up we are doing, and for first year it is every 3 months. For second year it is every 6 months, and onwards also I would like to do a follow-up up to 5 years.
Yes, absolutely perfect.
The
Now answering
investigations are done only if the patient is symptomatic. So you need not keep repeating the PET CT scan or all the investigations. The most important test is probably the mammography of the contralateral breast done annually. And if she is hormone receptor positive, and on tamoxifen and ultrasound of the pelvis to see for endometrial thickness.
yeah.
History taking and physical examination are very important. So when you take the history exam, you will be able to detect some signs and symptoms that there is metastasis is taking place. That is when you decide to do more advanced investigations.
So
Thank you, Vijay. That was
answering
probably the one very important thing what Vijay said, that physical examination and history taking. See, unfortunately, the era of MCQs, investigations are becoming more and more important. I would definitely appreciate what Dr. Vijay said, that way physical examination and history taking is very important when you are talking about even follow-up in metastatic disease.
Okay. So summarizing the answer to this question said by Dr. Apurva, Whenever we decide about following up patients who have been treated for breast cancer, you need to focus on three things. One is the local recurrence. The second is distant metastasis. And the third is any side effects of the therapies. Please understand that all the treatments offered to breast cancer patients have their own set of complications and side effects, which greatly affect the quality of life of the patients. And that is why all your investigations and clinical examinations will be towards these three. Like Dr. Vijay has rightly said, local recurrence is something which is best managed when detected the earliest. Distant metastasis, probably, like he rightly again said, doing a lot of investigations is not going to affect the overall survival once there is distant metastasis. However, it will definitely affect the quality of life and the disease-free survival. And that is the reason why regular clinical examinations with annual examinations are very significant. But the most important and what incapacitates your patients is the side effects and complications of therapies. And that is the reason why patients should be put on a 3-monthly surveillance, evaluate them not just for the recurrence of the disease, but more importantly, for the presence of side effects and complications, including locoregional, the lymphedemas, which are very distressing, the neuropathies, which are extremely distressing, and any restriction of your shoulder mobility. Other than that, all those side effects, which will be part and parcel of your systemic therapies. So this is how your surveillance should be planned: 3-monthly for the first 2 years, 6-monthly later on up to 5 years. In younger patients, you will probably have to survey them a little longer, and especially if they are BRCA positive, then they will definitely go in for a lifelong surveillance for risk of other cancers.
One more question, Anga. How does the surveillance differ when a patient opts for BCS than MRM? For small
the
tumor, say,
most important surveillance change is that the clinical examination will be very, very mandatory, and breast imaging will include the affected breast also. Now, also remember, this is an operated treated breast, so the architectural distortion is going to be significant. So this patient should be evaluated with the best possible mammography, and the best possible mammography is probably 3D mammography at present, along with the ultrasound, and wherever required, a MRI of the breast. Not as a routine, but wherever required.
Dr. Vijay, sorry, any inputs on your side?
Obviously, because the
Sir, your voice is breaking.
radiation changes of after
Dr. Vijay, sir, your voice is breaking. Is it? Can you hear, Abhijeet? Can you hear, sir?
No, sir.
Okay.
No, his voice is breaking. His voice
Yeah.
is breaking. I think what he was trying to tell was, because post radiotherapy, if there is a case of BCS, in an MRM, you would know any chest nodules. If there is a local recurrence, you'll find out. But when there is a breast BCS surgery is done, I think that is what he was trying to tell. That, you have given radiotherapy. So it becomes even harder because sometimes, there is a lymphedema of the breast. And you might need to do mammography every yearly. Like you have to do mammography every yearly of the same breast. And as ma'am also mentioned, it has to be a good quality mammogram to pick up a very small lesion if at all there is a recurrence. But when you see a BCS patient, mammography of both the breasts, they are totally looking different. Post radiotherapy, dense breast would have a very disturbed echo texture compared to the normal breast. So I think he was telling about the importance of the mammography or a local imaging, in post-RT BCS cases.
Thank you, Dr. Kinjal, for chipping in. Anga, any more inputs?
No, I think we are done. Abhijeet is looking absolutely gobsmacked.
Confused. No, I agree. See, now with chemotherapy and radiotherapy coming up, we have to fill in those steps. It is very important that we know what we are doing.
So
we cannot simply impose what we want to do on the patients.
yeah. Absolutely. Above all, the patient safety. And before we end this discussion, the last question that I have for Abhijeet is that how will you make sure or how will you prevent the chances of the patient getting lymphedema?
Ma'am, during surgery, I will do I will not go beyond the axillary vein, and I will do a limited dissection. Also, probably using a bipolar cautery. And post surgery, I will from post operative day 1, I will start the lymph physiotherapy.
And
And
what will you do pre-surgery? So the care of lymphedema does not start during the surgery or after the surgery, but starts before the surgery. Before you operate the patient, you have to evaluate whether the patient's ability to exercise, the patient's movement at that affected side shoulder is adequate or not. Are there any other predisposing factors which will predispose this woman for higher chances of lymphedema, like previous surgeries, like a smoker, like any other auxiliary treatment having been done? Whether the lymph nodal mass was too big to begin with, like this patient, she's a high risk patient for lymphedema, irrespective of whatever you do, because of the, just look at the amount of edema in the breast right now. The same is going to affect the arm. So previously, anticipating the risk of lymphedema is your biggest method of preventing lymphedema. Okay, so anticipate how much is the risk, evaluate how is the ability of the patient to take care of her lymphedema. Of course, preoperatively or intraoperatively, whatever you have said is the perfect answer. The best option or the optimal option would be considering sentinel lymph node biopsies wherever you can. And last but not the least is to advise the patient to take care of the lymphedema post-operatively in the form of regular physiotherapy, mobility exercises, and manual lymphatic drainage exercises. Okay. Now, what is it that will, all these we advise the patients, no blood pressure records on that side, no IV injections. For how long is that? Is it lifelong?
I don't know.
Okay, so most of us advise the patients to do it lifelong, because if the aim is that you have to minimize the risk of infection on that hand. However, there is no proven data which says that preventing the patient from measuring BP or taking intravenous injections or IV fluids on the affected arm for lifelong is going to minimize her chances of getting lymphedema in the future. So in the near future, especially till she does not complete her radiation therapy and a couple of months after that, it is good to advise nothing like that. But after that, it is a judicious use of that arm. Okay. More important is to advise her to look for early signs of lymphedema so that she can start treatment and manual drainage earlier on and not reach intreatable. And of course, now we have facilities of performing lymphosurgeries or lymphovascular anastomosis even during the surgery, especially when you use indocyanine green dye. It is possible now to evaluate the lymphatic status, and if major lymphatics have been harmed, you feel that this patient might end up with lymphedema, you can actually perform the lymph procedure during the surgery itself. Okay. So anticipating lymphedema is your best weapon against lymphedema. Okay. I think Apurva, I'm done with most of the discussion.
One more thing, especially when we talk about IV,
Mm.
role of port placement for post-operative chemotherapy, or what are the other options that we have?
Role of chemotherapy port placement for all patients of chemotherapy, especially in breast cancer, is most advisable, because one of the arm is going to be incapacitated for some amount of time, and you do not want that arm affected because of extravasations or the other venous blockade experiences that are very common post peripheral injection of chemotherapy. So port placement is advisable in all cases of breast cancer, especially so when you are probably going to give her a short-term dose-dense intensive therapy, especially when she's going to go in for trastuzumab, where the treatment is going to continue for more than a year or so. These are the patients where definitely port placement is the choice of giving chemotherapy. I personally would want to put in a port for all patients who receive chemotherapy in breast cancer.
So do you do it at the primary surgery itself, or is it placed later on?
Most of our patients now go in for neoadjuvant chemotherapy for aggressive cancer. So it is done at the time of the first dose of chemotherapy. I personally do not put ports at the time of primary surgery, but always at the time of first chemotherapy. But there are surgeons who put it at the time of surgery.
Bhavesh bhai, any inputs on your side? Dr. Kinjal?
Yeah, so the thing is, as rightly said by ma'am, majority of the time we go for neoadjuvant chemotherapy nowadays because of the biology of the lesion. Yeah, we do put port before we start the first chemotherapy, and the chemo is given on the next day. Like we put a port today, we give chemotherapy tomorrow. Dr. Vijay, I think he has just left. He puts port, like if the patient is going for a surgery first and going for chemotherapy afterward, he might put a port at the time of surgery. He puts it along with the surgery, so patient does not have to go for OT twice. But it is you do it as early as possible, and the chemotherapy which is given for breast disease are usually very locally irritant drugs, which if there is an extravasation, they lead to very hard veins. So any breast chemo which is to be given, whether it is a FEC which is given, FAC which is given, or AC followed by Taxol, and specifically when you have to give Herceptin for 17 doses, these are the places where you should put upfront. It is very safe and it becomes very easy for patients.
Yep, absolutely.
Okay, fine. So shall we close the debate then, Anka? What do you say?
Absolutely. Well done, Abhijeet.
Yeah,
So-
Abhijeet has
I
done
think-
quite well. He's well read. Abhijeet, you have done well.
Yeah, Dr. Vijay. Dr. Vijay, are you there?
And I think he's left. I think because there was
Okay.
a connection issue, I think he left. Yeah.
Yeah.
I think Abhijeet has done very well, and I think with so much descriptive chemotherapy part and everything, might be he is having more knowledge or more information. But I think this is a very important case, and at least you should think as a student that there are so many different theoretical aspects or different clinical. Sometimes what we as a clinician we suspect and it happens something different in a real day-to-day practice. So at least he should be very clear that this is the very different scenario also. And one important thing, we discuss almost all the things, but the one word is oligometastasis. What is oligometastasis and what to do or how to treat oligometastatic in a breast cancer cases, whether to do a surgery or not, whether to give if there is only one sternum bone met and it was asymptomatic, whether it can be included in the radiation therapy field or not, or whether a single bone mets like D4 or L7, what to do. And there is one also bone modifying agent, that is zoledronic acid bisphosphonate, or there is a denosumab, that is Xgeva, that generally we are using for a bone metastasis patients also along with chemotherapy.
Are you aware of what is a oligometastatic disease and how the treatment changes, Abhijeet?
Ma'am, if there is oligomets means less than 5 metastases.
Very
Uh,
true.
If there is oligomets, then we have to look. It is bone mets or visceral mets. In case of a visceral, we will continue our neoadjuvant chemotherapy surgery followed by radiotherapy. And if the mets are present after that also, then we can go for the surgery if oligomets are there. We can excise the.
Okay. So if I
So,
can,
Abhijeet, the thing is, we have to sorry, ma'am. So, Abhijeet,
yeah, you go ahead.
the intent should be very clear when we begin with. So, if you talk, you rightly said, that oligomets is if there are less than 5 mets. But just think about a scenario, because this is again to be oligomets is always to be discussed in a multidisciplinary team. Because what will happen? There are 5 metastases. I'll give you an example. One is in brain, one is in sacrum, one is in liver, one is in lung. 4 lesions. The sacral lesion is a huge lesion. It's a 6 centimeter lesion compressing on the nerves, and patient has severe back pain, severe pain in the limbs. Now, this patient has 4 lesions, but this is not an oligometastatic curative disease. So, upfront thing, whenever oligometastatic disease is there, it has to be discussed in an MDT whether this patient is, the important word is potential, whether this patient is potentially curative. Because earlier what used to happen was any metastasis, you would consider the patient as a palliative patient. But if you can offer a local treatment, either in the form of surgery, a radiosurgery, or a radiofrequency ablation, so if you can add a local treatment after the systemic treatment, and you can achieve a cure for this patient because the metastatic burden was less, then this is a potentially curable patient for a oligometastasis disease, right? So this all oligometastatic patients where you are thinking about cure, systemic treatment has to be the first treatment. The other important thing is, the biology of the lesion. A patient with ER/PR positivity, a HER2 negativity, or a triple positive, these are more likely to be benefited from aggressive approach than the triple negative one. So if there is a triple negative disease and has two lesions, one in liver and one in bone, or one in brain and one in liver, this may not be as curative as the one which was ER/PR positive or HER2 plus or minus. Right? So that is very important, which you discuss in an MDT for an oligometastatic, and then take it whether it is a potentially curable or not. Right, ma'am? You want to add anything?
Yeah, absolutely perfect, Kinjal. And the most important word that Dr. Kinjal told you was a potentially curative disease. Oligometastatic disease is always a potentially curable disease, which means that you need to evaluate the oligometastatic patient on neoadjuvant chemotherapy at regular frequency to see if there is a possibility of cure. You started with oligometastatic disease, but the metastatic sites did not resolve on your primary chemotherapy. This is no longer a potentially curable disease. Okay.
Bhavesh bhai, any more
We're done.
inputs?
I think I had given to a surgeon audience maximum input. I don't know, but I just, as a good academician, I just want to share so many information, because we still feel, even at the end of 25 years in oncology, we still feel that every breast cancer case is a real challenging case, and so many things to learn. That's why, and I feel still that surgeon is the main person, or surgical aspect, or the surgeon is the main key person to treat or to understand the breast cancer and to breast biology.
So on that heavy note by Bhavesh bhai, I think we should all end the discussion. Thank you, Bhavesh bhai, Anga, Dr. Kinjal, DG Vijay sir. Special thanks to you and Dr. Saranjit. Please pass on my thanks to Dr. Saranjit. Also, we will conclude the session then, sir.
Yes, please. Thank you so much. Abhijeet, well
Thank
done.
you so much. Thank you. Thank you.
Congratulations, Abhijeet, for a wonderful case discussion.
Thank you.